We have seen novel treatments for GIST. We have also seen a very interesting political presentation because it's about treating sarcoma patients in specialized centers, which is something that is very well organized in Northern Europe, like Scandinavian countries, and it has also been adapted by the UK. And France has put a lot of efforts of enacting that kind of strategy in their country. And they have tried to analyze whether treating patients in centers really offers an advantage over having them treated anywhere. And what they have shown is that the local disease control is highly significantly better if patients are treated at a reference center. What we've seen today is the latest update of a clinical trial of a new inhibitor, which, unlike the currently available KIT inhibitors, is a so-called type 3 kinase inhibitor. So it is somewhat an allosteric inhibitor, which means it is less dependent on the actual ATP binding pocket, which means it is more specific against KIT, and it's less dependent on secondary resistance mutations.
In 70 patients with GIST and other tumor types, we proved that DCC-2618 is safe, and the safety profile was favorable compared to other similar compounds which are currently available or licensed by regulatory authorities on both sides of the Atlantic. As far as the efficacy is concerned, in heavily pretreated patients population with GIST, DCC-2618 showed unprecedented level of activity which supported further development into phase 3 study.
We also saw an important presentation today about a trial that dates back quite a while. So it was the final analysis of the adjuvant ERTC trial, which tested 2 years of imatinib against no treatment in patients with localized and resected GIST.
This was the final analysis of a clinical trial on adjuvant therapy with imatinib in localized gastrointestinal stromal tumors. The design of the study was very simple. It was a randomized trial between imatinib for 2 years versus no further therapy after surgery in localized gastrointestinal stromal tumors. This is the final analysis with a follow-up of more than 9 years. And basically we confirmed the results of the interim analysis with a trend in favor of imatinib, a non-statistically significant trend, in the subgroup of high-risk GIST patients. The practicing community, the message is standard treatment in localized high-risk GIST patients is adjuvant imatinib for 3 years following the results of one of the 3 trials which have been published. And I would say that the final results of our study basically confirm that this should be and should remain standard practice.
People with low and intermediate risk should just not get imatinib. I think this is made very clear from this trial. The other point is we have to make up our minds about the future strategies in the adjuvant setting. So it's more about giving continuous imatinib or looking for approaches that actually eradicate the disease. So that means we may have to combine a KIT inhibitor with something that induces apoptosis more efficiently.